Okay. So, hi, evening friends, evening everybody, and bache, let us start. Let us start with our vibe image-based pathology discussion. So, this is a discussion in which we will take care of the images which have been asked in the previous papers, and will also take care of the prospective images that can be asked in both AIIMS as well as the NEET exam. You very well know that images are the main make or the break factor. So before we go further, let me see if everything is working fine or not. Yes, it is. Perfect. So starting with our first slide, let us have a look at the first tumor. It has been given to you that it is an ovarian tumor. Diagnosis. This is the actual session. This is how I will be taking the vibe session. We will be going at this speed so that we are able to cover more images in shortest time span. It has been given to you as an ovarian tumor. What do you see here? Diagnosis. देखो बच्चे, this is an ovarian tumor. This is an ovarian tumor. The examiner tells you that the ovary has been opened up. They have cut open the surface of the ovary, and you are able to see the presence of papillary projections. You are able to see papillary projections. Firstly, next point, it is a unilocular tumor. It is a unilocular tumor. Answer. What will you mark? I'm waiting for your answer on this. What will you mark in this? What do you see? It is serous ovarian tumor. It is a serous ovarian tumor. Dekho, let us have a look at the salient features of ovarian tumors. I can divide the ovarian tumors. Into three main categories. That is the ovarian tumor. Ovarian tumors, I can divide them into three main categories. That is the serous ovarian tumors, the mucinous ovarian tumors, serous, mucinous, and the germ cell tumors of the ovary. Serous, mucinous, and the germ cell tumors. First point, what percentage of total ovarian tumors, percentage of total do they form? All three account for 30% of all ovarian tumors. Out of which benign and malignant, this table has been asked in numerous formats. Serous tumors, 70 to 75% are benign versus 25 to 30% which are malignant in nature. Malignant tumors, mucinous tumors, approximately 80% are benign, 20% are malignant, versus germ cell tumors, in which approximately 95% are benign and only 5% are malignant in nature. So first easy question, most common malignant ovarian tumor, serous cystadenocarcinoma ovary. Most common benign ovarian tumor is germ cell tumor of the ovary, and benign germ cell tumor of the ovary is called as dermoid cyst or a teratoma. We'll be seeing this. Whatever is being written on this slide, I will show you the gross and microscopies of these one by one. Next point. Hi Shweta, hi bache, and Govind, namaste sir, namaste dost. And what you see here is most common malignant ovarian tumor. Most common malignant is serous cystadenocarcinoma ovary. Most common malignant, serous cystadenocarcinoma ovary. You know this. Next point. Serous tumors, they are bilateral and unilocular. That is, they do not have the presence of numerous septa in between. Versus mucinous tumors, which are unilateral. And multilocular. They are unilateral and multilocular. Meaning you see the presence of numerous fibrous septa in between. That is mucinous, they are unilateral and multilocular. Next point, it has even been said that if mucinous tumor is bilateral in nature, then the chances of it being mucinous are low. Next, so this is what a serous ovarian tumor looks like. You have the presence of papillary projections and unilocular in nature. Versus, have a look at this one. Firstly, it is a very large ovarian tumor. It is a very large ovarian tumor. Next, showing the presence of multiple septa in between. It is multiseptate. It is multiseptate. So diagnosis, multiseptate and extremely large. Diagnosis, mucinous ovarian tumors. Diagnosis, mucinous ovarian tumor. Mucinous ovarian tumor. Next, because of the presence of mucinous ovarian tumors, these tend to be largest of all ovarian tumors. They tend to be largest of all ovarian tumors. Next point. This gets us to our next image. In microscopy, in gross, that is diagnosis. This is a characteristic gross image. What you see here is the examiner has told you that it is an ovarian tumor. Diagnosis. What you see here is the presence of enlarged ovaries, which are yellow in nature. I mean, what would be more bright yellow than this? This is yellow in nature. This is yellow. So what you have here is a yellow color given to the ovarian tumor because of the presence of intracellular lipid. This is a characteristic gross image. Associated with granulosa cell tumor ovary. Next point, for some of the students, this would be repetition of our yesterday night session, but there were a few technical issues in that session. It was taken on the Unacademy app. There were a few technical issues, so I am having a recap of the initial 15 minutes of the session. And for the new students, this is how the images in Vibe are discussed. That is, I am having a complimentary 2.5 hour session on Vibe, in which about 300 to 350 extremely high yield pathology images will be covered. I'll be telling you the details of the same towards the end of the session, but this would be the speed of the session. That is, we will discuss what we see in the image, the salient features of the same, diagnosis, and 1-2 additional points. This is how Vibe is taken, visual image based pathology session is taken. So yellow discoloration to the tumor because of intracellular lipid. This is granulosa cell tumor. Next point, granulosa cell tumor. Let us have a look at few salient features. This is the most common estrogen secreting. Ovarian tumor. Firstly. Next point, clinically, now if it is secreting estrogen, that estrogen will have some effect on the body. So if I divide the female cycle into three parts: pre-puberty, reproductive age group, postmenopausal. When will increased estrogen be most alarming? Postmenopausal. Just a way to remember. So clinically, majority of the patients are in the postmenopausal age group. Which present with bleeding per vagina. Next point, it can also present with precocious puberty. If it occurs in the prepubertal age group, the patient can have precocious puberty, or in the reproductive age, it can present with menometrorrhagia, that is increased bleeding, reduced cyclical pain in the breast, all the features of increased estrogen. This is granulosa cell tumor. Next point. What I'm interested in is the microscopy of granulosa cell tumor, and I'm sure you know this. Microscopically, it shows the presence of col-exner bodies. Microscopically, very, very important. And this is important to identify, because keep it as simple. In an ovarian tumor, if you are able to see the presence of a col-exner body, this is a col-exner body, it shows the presence of tumor cells arranged, in which you have pink, eosinophilic pink structures in the middle, which looks like a telephone. You pick the receiver and dial from the middle. Col-exner body. This is what it looks like. This is a must identify structure. Col-exner body seen in granulosa cell tumors. Col-exner body seen in granulosa cell tumors. First point. Next point, immunohistochemistry. Next point, IHC, immunohistochemistry. IHC Granulosa cell tumors, they are inhibin, melanae and calretinin positive. They are inhibin, melanae and calretinin positive. This is granulosa cell tumor. This is granulosa cell tumor, and this is what a granulosa cell tumor called external body looks like. So we have seen both the gross as well as the microscopy of the same. In an ovarian tumor, if it is not called external body and it looks complicated, mark it as Schiller-Duval body. I'll show it to you. Next, have a look at this gross. This was an ovarian tumor in which the central material has been scooped out. The central material has been cleared, and you are able to see some solid structures. Firstly, all the central material has been cleared. What are the solid structures? These solid structures which are marked, they are the Rokitansky protuberances. First point. Next point. The structure, all the material that has been cleared was the cheesy material, hair follicles, teeth which were extruding out. That is, this is a case of teratoma. You know that teratoma, it is the benign ovarian tumor. It is the most common benign ovarian tumor. 30% of all ovarian tumors are the germ cell tumors, 95% of which was teratoma. That is, it is the most common benign ovarian tumor. It has all three layers: ectoderm, mesoderm, endoderm. Can it undergo malignant transformation? Yes. Most common malignant transformation in teratoma, meaning teratoma has all three layers: ectoderm, mesoderm, endoderm. Which part undergoes malignant transformation? Which is ectoderm. The most common malignant transformation is squamous cell carcinoma. You very well know that squamous cells, they can be benign squamous cells which are present in teratoma. Skin is present. That can undergo a malignant transformation to squamous cell carcinoma. This is the most common. Followed by others are melanoma and thyroid carcinomas. Which thyroid carcinoma is most commonly associated with teratoma? PTC, papillary thyroid carcinoma. So in an ovarian tumor, if I see PTC, papillary thyroid carcinoma, this does not mean that it has metastasized from thyroid to the ovaries. Not at all. It was malignant transformation of a teratoma. Next point. We saw that teratoma has all three layers: ectoderm, mesoderm, endoderm. But it can be monodermal also. Most common monodermal teratoma is struma ovari. Struma ovari, that is the presence of thyroid in ovary. Followed by, which is the second most common monodermal teratoma? It will be there, not to worry about it. First, have a look. I am not taking lots of queries today in the vibe session. This is because in the actual visual image based session that we'll be having tomorrow evening again, this is just, and this was our yesterday's session, this is the way it will be conducted. So I want you guys to be comfortable with this speed of the session. That is why today I'm not taking queries, but yes, it will be available. Most common monodermal teratoma is struma ovari, followed by, which is the second most common monodermal teratoma, that is carcinoid tumors. Most common is struma ovari, followed by carcinoid tumors. Next point. What is the significance of Rokitansky protuberances? They were originating from the wall and coming towards the lumen. This is where most commonly malignant transformation occurs. Rokitansky protuberances. Next point, diagnosis. Now, I already told you that if it is not a col external body, and it looks complicated, close your eyes in an ovarian tumor and mark it as Schiller-Duval body. What do we see in a Schiller-Duval body? It has a central blood vessel, because this is the blood vessel. How do I know it's a blood vessel? It is a luminal structure with presence of RBCs in the lumen. It is a luminal structure with RBCs in the lumen, showing the presence of an outer papilla, showing the presence of an outer papilla with cuboidal epithelium. Outer papilla with cuboidal epithelium. So central blood vessel with an outer papilla with cuboidal epithelium. Schiller-Duval body. Seen in endodermal sinus tumors. Seen in endodermal sinus tumor. Endodermal sinus tumors or yolk sac tumor. Seen in endodermal sinus tumor or yolk sac tumors. Schiller-Duval bodies. Next point. Diagnosis. It has just been given to you that this is an ovarian tumor. Diagnosis. देखो, this shows a very monomorphic appearance of cells. All the cells are similar looking. You have a central nucleus. With clear cytoplasm. Central nucleus with clear cytoplasm around it. Central nucleus with a clear cytoplasm. All the cells are similar appearing. That is, this is a good prognostic ovarian tumor. देख के लग रहा है that it is not that bad an ovarian tumor. That is dysgerminoma. It has the presence of monomorphic appearance of cells. Dysgerminoma. And you know that dysgerminoma is the ovarian counterpart of seminoma. It is the ovarian counterpart of seminoma. Next point. Seminomas. They are which tumor marker positive? Answer bache. I'm waiting for your answer on this. Seminoma. They are plaque positive. Placental alkaline phosphatase. Plaque positive. So the question will not always be diagnosis. The examiner can give you this image with some vague history. The history will not help you in making a diagnosis. Examiner will give you this microscopy and ask you the tumor marker associated. Beta HCG, plaque, NSE, so on, and the answer was plaque. Placental alkaline phosphatase positive. Next point. Diagnosis. An important image. This is a gross image. In which you are able to make out that this is the uterus. You are able to make out that this is the uterus and cervix. Uterus and cervix with presence of uterus and cervix are okay. With presence of bilateral ovarian tumor. Diagnosis. Before I go further, Shabnam, हाँ बच्चे, LDH is also elevated in seminomas, I agree, but LDH is a non-specific marker, na? It is elevated in numerous tumors of the body. The specific marker for seminoma, plaque, that would be the best answer, plaque, placental alkaline phosphatase. Next, it is a bilateral ovarian tumor, that is Krukenberg's tumor. This is a bilateral ovarian tumor, that is Krukenberg's tumor. Next point. Achha, suppose the question is asked, most common primary bilateral ovarian tumor. Ovarian tumor are the serous tumors. Differentiated from most common bilateral ovarian tumor, which is metastasis. So have a good look at what the examiner is asking you. Most common bilateral, metastasis. Most common primary bilateral ovarian tumor, serous tumors. Next point. Diagnosis. Achha, before I go to this, first tell me the answer to this. Which is the most common site? Just a sec. Let me add 1-2 slides here. And now tell me the answer. To which is the most common primary site of metastasis to ovaries. We have just seen that most common bilateral ovarian tumor is metastasis. Answer. Most common primary site of metastasis to ovary. Answer bache. Normally in face-to-face classes, students fall into this trap and say the answer either has GIT or breast. No. Most common primary site of metastasis is the tumor of Mullerian origin. It is the tumor of Mullerian origin. Please do not forget this. Tumor of Mullerian origin. No, Abhi Bunyani bache, you fell into that and said it as stomach or GIT. No. Most common primary site are the tumors of Mullerian origin. That is those of the uterus. Next, uterus fallopian tube, uterus, fallopian tube, or contralateral ovary. This is the most common primary site of metastasis to the ovary. Tumors of Mullerian origin. Next question. Most common extramullerian site. Most common extramullerian primary site. Most common extramullerian primary site of metastasis. Extramullerian primary site of metastasis to ovary. This was your answer of GIT. This was your answer of GIT. And in case of Krukenberg's tumor, it is the stomach and breast. So have a good look. Have a good look again at what the examiner is asking you. Do not forget the tumors of Mullerian origin. That is what I wanted to discuss. Next point. I need not even say this now, that if this has been given as an ovarian tumor, now it is a spotter. Examiner can either give you both the slides, that gross specimen of bilateral ovarian tumor with this microscopy, or he can simply give you that gross and ask what would be the microscopic feature and give you 4 images, out of which this has to be chosen. Question can be framed in any manner, but this would be the bottom line. It shows the presence of Signet ring shaped cells. What you see here are the cells. Which look like a ring. The nucleus is present at periphery. That is Signet ring shaped cells. Signet ring cell shape. Seen in Krukenberg's tumor. Krukenberg's tumor. This is what the Signet ring cells look like. Next point, diagnosis. So we are done with our first set, that is ovarian tumors. The first set of slides that I wanted to discuss today was ovarian tumors. What we did till this point, we had already covered in the initial 15-20 minutes of the session yesterday night. Next point, diagnosis. Answer. I like you guys to tell me this. Firstly, ALL. Your options would be ALL. Next, M0, M3, M4, M7. ALL, M0, M3, M4, M7. These are your options. Everybody answer. What will you mark? ALL, M0, M3, M7. ALL, M0, M3, M4, M7. Firstly, what is the technique? This is a peripheral smear. You are able to see the presence of RBCs which are well spread apart in the background. Next point. You fell into that trap. Smart clinician bache. Every acute leukemia is not a case of M3 na. Danish Shabnam, no. This is how we go wrong in the paper also. This is peripheral smear. RBCs are well spread apart, showing the presence of very large cells, about 2.5 to 3 times the size of an RBC. Showing the presence of very large cells, about 2.5 to 3 times the size of an RBC, with a large nucleus. It has a large nucleus, moderate amount of cytoplasm. All these are with cytoplasmic granules. All these are the features of myeloblasts. Making it as a case of AML, acute myeloid leukemia. You also are able to see an OR rod. You are even able to see the presence of an OR rod, further confirming that this is a case of AML. Now, the point was that all these are monoblasts, but they have moderate cytoplasm with such indented appearance of the nucleus. Very, very important slide. This is an important prospective question. All these are the monoblasts, making the diagnosis as AML, M4 or monocytic leukemias. What I wanted to say was it is a case of monocytic leukemia, AML, M4, M5. First point. So when the examiner will give you this question, he might not just ask AML, M4, M5. He can either ask you which CD markers or which immunohistochemistry will they be positive for. Immunohistochemistry, NSE positive. Monoblasts are NSE, non-specific esterase positive. They are non-specific esterase positive. Next, which CD markers, which immunophenotyping are monoblast positive for? They are CD14 and CD64 positive. 14 and 64 positive. These are the next level of question that can be asked on this. Next point, he can even ask you the translocation associated. Translocation. So translocation seen in this. Translocation inversion 16. Now inversion 16 as such is associated with a special subtype of monoblast, that is M4EO. Monoblast with eosinophils, M4EO, but it can be associated with inversion 16. Next point, coming to your query, one of the most common mistakes that I was expecting in this slide was a diagnosis of M3. That is what you asked also, Smart Clinician. But what you see, though I like your name, what you see here are, these are the RBCs. It is a case of peripheral smear showing the presence of very large cells, 2.5 to 3 times the size of an RBC, with presence of multiple OR rods. Which are you able to make out all these OR rods? So do not confuse every case of AML as M3. This has multiple OR rods. Cell with multiple OR rods are called as faggot cells. Cells with multiple OR rods, they are called as faggot cells. Faggot cells seen in AML-M3, that is acute promyelocytic leukemia. Seen in AML-M3, that is acute promyelocytic leukemia. Everybody knows the translocation and the fusion transcript associated with this. Answer, bache. Translocation in AML-M3. Translocation. Answer. Translocation 1517. Fusion transcript. If this translocation has occurred, it will lead to the formation of a fusion transcript. Which one? PML RARA. Translocation 1517, fusion transcript, PML RARA. This is the best prognostic AML. Therapy, ATRA, all trans retinoic acid, ATRA. You already know most common cause of death in M3, DIC. Most common cause of death in M3, DIC, disseminated intravascular coagulation. So I can safely say DIC is most common in which AML? M3. Last question. Which CVS lesion or which vegetative endocarditis is associated with M3? Let me write it on the top. Which vegetative endocarditis is associated with M3? Answer. There are 4 vegetative endocarditis: RHD, rheumatic heart disease; infective endocarditis; NBTE, non-bacterial thrombotic endocarditis; and limb and sac. M3 is associated with NBTE, non-bacterial thrombotic endocarditis, NBTE. This is M3. So I hope you will not confuse monoblastic leukemia from M3, which showed the presence of faggot cells. Next point. Before we go further, now have a look at the vibe session, bache. This is what basically we did yesterday, the session 1. Yesterday was session 1. We did it for about 1.5 hours, but we have already covered the first 15-20 minutes of the session in our today's this YouTube discussion. Firstly. Secondly, tomorrow, that is on 27 September, tomorrow at 6:30 p.m. the second visual image based session of pathology, time duration of which will be around 1.5 hours. It is 1.5 hours complimentary session for everybody will be there. All AIIMS and the NEET PG aspirants, bache, you have to attend the pathology vibe session, absolutely no doubt about it. It will be going at this speed only at which we discussed. So those of you who thought it is slightly faster, more content should be there, no. I'm saying this very frankly. This is because we have to cover all the high yield images in a particular time frame. So tomorrow from 6:30 p.m. the link of the same is on my Telegram group. So for the Telegram group, absolutely nothing. I'll just tell you, for the Telegram group, on Telegram, simply type it as Sushant Soni Pathology, and the link will come up in the Telegram group, and you will be able to have a look at all the complementary classes. Next point. In this month, that is in October, you very well know that November AIIMS, the dates are out and everything. AIIMS oriented crash course, again complimentary for everybody. With respect to pathology will be there. I'll be doing 5 sessions of the same, that is 2 hours per session. 2 hours per session. I'll take 5 sessions in which the previous 3 year questions and prospective questions will be taken care of. Next point, I will be dividing these 5 sessions into two sessions of systemic pathology. They will be in this sequence only. 2 of general pathology, and the last one session will be of hematology, with much more stress on oncohematology. RBC disorders and bleeding disorders, as such, you are almost comfortable with them. So these 10 hours I launch it every year. There it is, either on YouTube, on my app, Unacademy, everywhere. This is one of the most high yield sessions of pathology. Speed is much faster, but every paper has about 28 to 30 questions from path, out of which close to 22 to 24 questions come from these 10 hours of the session. This is what we are seeing in the past 2.5 years. Lastly, Shabnam, for FMG bache, for the December FMG exam, for the FMG, there would be a special 6-hour crash course in pathology. This will be catering to the new pattern, firstly. Secondly, on Unacademy app, this the last point, rest everything was complimentary. Exclusively for the FMG, 1 month rapid revision module has been started, in which we will take care of your 15 to 16 main subjects. The main target of the rapid revision module is to get you 150 plus score. 1 month from 5th October to 28th October, with 8 hours of class, per day has been launched, which is for the plus subscribers. So in case you have absolutely any queries or anything that you want to ask me, please drop me a WhatsApp message. Please do not call, I will not be able to pick the call. Drop me a WhatsApp and give me 2-3 hours, I'll certainly be replying. For the subscription, you can use this code, or you can contact me for the same. Needless to say, bestest of luck for the exam. All the exams are coming up. The November AIIMS, the January NEET, the December FMG, everything is coming up. Keep yourself with a positive mind frame, and you will get through. Take care and good luck. But whatever you do, do not miss the second session. Do not miss the second vibe session of tomorrow on the Unacademy platform at 6:30 p.m. Done. It's complimentary. Done. Thank you and take care.